Can get to clinic. So we're going to talk about esotropia today. I got the email that everyone wanted more cases, so I put in a few cases. I'll start off with one, and then we'll kind of get through the meat of it, and then I'll do a few cases, and we can kind of leave time for talking at the end. So, 7-month-old girl. This is a pretty typical case. 7-month-old girl comes in with her mom. Mom is really concerned that she's crossing her eyes. I thought it'd be good to go over a few questions that are really strabismus, esotropia, pediatric specific that you want to go over in addition to your HPI. So I'm not going to put anyone on the spot, but does anyone know of any specific questions you might want to ask the mom who is coming in with this concern?
How frequent and when is it happening?
Yep, definitely.
When did it start?
Yep. So those are very important. So I just, in addition to your normal routine question asking, for strabismus, how old are they when it first starts? A lot of these questions, I think some of you have seen some of my, when I'm in clinic with you and I go through my esotropia kind of little talk, your history really gives you a great idea of what to rule out in your differential just based on when it started, the age. And it's important to remember that parents are very poor historians. They don't, just like adults, they don't really understand the eye. They don't know which eye they're talking about. So obviously, every once in a while, you'll get a great historian, and the parents are pretty accurate. But you have to do a really good history and then kind of put it on the back burner, because I've had patients come in, their parents are telling me that their eyes are crossing, and it's actually ptosis. So they just know something's wrong. So you want to ask how old they are when the problems first start, all the time or intermittent. Is it worse close up, far away? Is it one eye? Is it both eyes? And are the eyes turning in or out? And they can sometimes say they're crossing in towards the nose and they're actually drifting out. So you kind of have to take some of it with a grain of salt. So, is there anything on medical history that might be specific you want to ask about for crossing or strabismus? Think of anything specific?
Yeah, birth history.
Yep. Birth history is important. So things that I think about, you always want to ask if they're full term. That's something we forget, because especially when you're not dealing with kids a lot, it's not something you're going to ask an adult. But don't forget to ask, were they born premature or full term? Were there any complications with the pregnancy or delivery? So methadone patients, kids who go through withdrawal, prematurity, ROP with or without laser, kids who have BP shunts, hydrocephalus, meningitis. Those are all things that are going to make them slightly more likely to have strabismus. And so when you're looking at someone who you think might just have pseudostrabismus, if they have something in this history, your kind of antenna is going to go up, and it's going to make you more likely to think there really is something going on. So family history, you're going to ask pretty much anything you can to try and stimulate their memory. I ask about lazy eye, even though I know some of you have heard. I don't really like that term. I think it's really just has a really negative connotation, but that's what families know. So I ask them about lazy eye, but you can say any history of crossing, patching, glasses, surgery, blindness, anything at all, and they always forget, especially because it just becomes natural for them. It's who they are, and they don't think about it as a medical issue sometimes. You want to ask about cataracts and look at the parents. My favorite story is I was sitting and talking to a family who brought their child in for possible strabismus, and I was like, is there any family history of the eyes drifting? And the dad's looking at me and he says, no. And I'm looking at him as he's saying this, and his eye is turning out. So they really sometimes forget, and sometimes it just takes a little, the right word to jog their memory. So this is a 7-month-old girl. Mom tells you that either eye drifts in towards the nose. Started around 3 months of age. It's intermittent, but she mostly sees it in pictures, and mom's really bothered because other people notice it. And there's no family history or medical history. That's significant. So the differential diagnosis for esotropia, no, again, if you can think of anything in your differential, I'm not going to put anyone on the spot, but can you guys call out a few things that you want to think about in when someone comes in with this complaint? Pseudo, yep. Infantile, yep. The next big group is accommodative or acquired. Honestly, you should really think pseudo, infantile, acquired. Those are the really big categories you can think about that can kind of point you in the right direction. So I just kind of included everything from your book, and I kind of like thinking about it in these terms. I think that a lot of times when someone comes in with a complaint of strabismus, especially when you're a first year, it can be really confusing. Your head's spinning because there's so many different types of strabismus, and you're really nervous about examining the patient. The parents are making you nervous, and the kid's not cooperating. So sometimes it's good to just have a nice schematic to rely on. So you want to think about it in terms of concomitant esotropia. So you have the pseudostrabismus, infantile, and then the acquired. And it's really important to remember that accommodative esotropia is a form of acquired esotropia. So that way you're not getting confused. And then all the other types here are other forms of concomitant acquired esotropia. And then you have the inconcomitant. So I think a lot of these are covered in other sections, but you have the restrictive, like the thyroid eye disease, the six-nerve palsy, the fractures, fibrosis, esotropia with high myopia or sagging eye syndrome, Duane's, and Mobius. So some things that I wanted to go over, important things on your exam that you should be looking for with kids. So you can describe their vision as fixed and follow. You can describe it as central steady maintained or protest with cover. Don't use sound. This is one of my big pet peeves when you're checking vision in a kid. Those light up toys are great for extraocular motility, but they have sound. I mean, if you're using something to test their vision with sound, you're testing their hearing. You're not testing their vision. So that's really important to remember. A lot of times parents will come in and they'll say, I know they can see. I walk into the room and they look at me. I mean, they could be hearing their footsteps. So don't forget not to use something with sound for vision. And then you just want to go through your normal routine. Just because the kid's crying and not cooperative and the parents are on your case and trying to be helpful by talking to their kid, but they're actually making the exam a little bit harder because the kids are paying attention to the parents and not you, just stick to your routine exam. It'll get you the answer every time. So extraocular motility, you want to see if it's full. Is there any sign of restriction? If you're worried that there's something going on with the abduction or adduction deficits, make sure you're doing ductions and versions because you could be misled. At young ages, don't forget, they have a very underdeveloped smooth pursuit system. They develop it first horizontally and then vertically. So sometimes they're not following your little light or your little toy up and down just because they're too young. They haven't developed that ability yet. You want to make sure you're really going slow. If you go too fast, they're not going to follow you. I know a few times I've had this situation. I think there's been a resident with me, and it looked like they weren't following anything, but if you slow down, they can actually follow the light. So make sure you keep that in mind if they're really little. For the alignment check, cover and uncover testing, alternate cover. Hirschberg is just the corneal light reflex, and modified Krimsky are the most common ways to measure. You want to look for ptosis. Like I said, they may think the eye's crossing, and it's actually a totally different animal that you're dealing with. Red reflex, I think, is something that's not done enough on pediatric exams. It's something we forget. It's really easy just with your direct. The Bruckner reflex is when the light reflex is abnormal because of strabismus. And you can pick up cataracts, thinking about a sensory esotropia, or big refractive error changes can be picked up on red reflex. So don't forget to use that. And always cycloplegic refraction posterior exam. Okay, let's move on. From there, so this first case, the vision is central steady maintained, pupils are normal, extraocular movements are full. On your exam, they're orthophoric, they have a wide nasal bridge, and everything else is fairly normal. Their cycloplegic refraction is 250, and the child looks similar to this picture. So what do you guys think this is? Yep. And I got this picture from the AAO website, and I noticed that the child has a small anisocoria, but ignore that. That's not why I put the picture up here. You can see the wide nasal bridge and the epicanthal folds. The corneal light reflex here is equal, and I don't know if you can tell, the child is slightly at an angle and looking off to their right, and that's really common. A lot of times with pseudostrabismus, I'll have the family just show me a picture, And every time they're looking slightly at an angle, and you see that optical illusion where they're covering up that the white part of the eye, the sclera here. So that's kind of a telltale sign. So pseudoesotropia is the false appearance of esotropia. The visual axis is actually aligned, and it's due to the flat, broad nasal bridge or epicanthal folds. You can also have pseudoesotropia appearance because of a narrow interpupillary distance or negative angle kappa. So ocular instability of infancy, this was a new addition to the book from the version that I had as a resident. But it's important because people worry about this. Parents will ask you about this. It's a variable, transient, and intermittent strabismus that prevents in the first few months of life. It can be esotropic or exotropic. It usually will go away by 3 months, sometimes a little bit longer, up to 6 months I'll even give them. But the big caveat is that it has to be transient, intermittent, and improving. If you have a patient that has a large deviation and it's constant or it's always one eye, well then all bets are off. You really should see the patient. I always err on the side of seeing the patient because you can either provide reassurance or you could pick something up. If they have a history of hydrocephalus, VP shunt, or any other medical issues, they may be more likely to have actual pathology. So infantile esotropia is one of the big categories that we see. These patients, typically the signs of esotropia are going to present by 6 months. Sometimes they don't come in. The parents will say, oh, it started around 3 or 4 months, and then it's a year later, and they finally are bringing them in, or the pediatrician for some reason tells them it'll go away on its own. But usually the signs have started by 6 months. There can be a family history of strabismus, and they're more likely to have infantile type esotropia with hydrocephalus, prematurity, and cerebral palsy. Infantile esotropia is more likely to have cross fixation, and we'll talk about that a little bit on the next slide, I think. They can develop amblyopia. It's more common when one eye crosses, but I think one question I had on OCAPs or on the boards or something like that was something to the effect of which type of esotropia is more likely to get amblyopia, and it's actually accommodative compared to infantile because they get this cross fixation. Typically, they're large angle, comitant, and they have full versions inductions, but don't forget they can look like they have an abduction weakness because of this cross fixation. So you want to make sure, I like to do ductions, just cover one eye. It works pretty well. You can do doll's head maneuvers or even spin the baby. I've actually had to take a few times. I couldn't get the baby to move their eyes like I thought they should, and you just pick up the baby and I sit in my chair and kind of spin them, and you can kind of stimulate eye movement that way. Just make sure that you are comfortable holding a baby like that and that the parents are too, and make sure not to drop them. The infantile esotropia patients are going to also be at risk for DVDs, inferior oblique overactions. That's important in order, once you make the diagnosis, to talk to the parents about. And usually 50% of patients can develop them after 1 or 2 years old. Infantile esotropia patients also have latent nystagmus. Important to remember when you're checking vision, look out for that because you want to make sure you do fog vision testing if they have a high degree of latent nystagmus. And they typically are going to have a low amount of hyperopia. These aren't +4, +5 kids. They're probably going to be around +1 or +2. So you want to do a full exam. Correct. This is going to be a common theme throughout strabismus. You're going to do a full exam, make sure there's no pathology, treat any underlying pathology, correct for significant refractive errors with the full CR. I'll try corrections for over 150. The lower it is, the more I count to the parents that it probably won't do much. Like if it's a +2 or a +250, I'm like, yeah, we'll try it, but we'll see. It might not improve anything. If it's 150 or less, I really don't think it's going to do much. And then you can perform surgery. If the amblyopia, even if it's not fully treated, you can perform surgery. But you want to make sure you communicate with the family that they still need to patch. I obviously am going to start patching as soon as I see any sign of amblyopia, because you want to get them in a good routine. So many times parents think that surgery is going to correct all of the issue, and you just really have to kind of drive it home that they're going to have to patch no matter what. And early ocular alignment with surgery can provide better fusion, stereopsis, and long-term stability for these patients. Your goal of surgery for esotropia is obviously orthotropia, but that's sometimes not really a reasonable goal. It's really orthophoria within 8 to 10 diopters of orthotropia. Monofixation syndrome is considered a success in surgical realignment. This is peripheral fusion, central suppression, and a favorable appearance. This microtropia can provide stability without bifoveal fusion. So they'll still show suppression on the Worth 4-dot test, but they're going to be within 8 to 10 diopters of orthotropia, and they're not going to have double vision. They have good alignment. So when do you operate? So this is actually, there's some variability here. So earlier the better in these really large deviations. Most people, I think, want to operate by 12 to 24 months. You can operate as early as 4 to 6 months. There's 2 studies that the book talked about. Congenital esotropia observational study that when 40 diopters of constant esotropia after 10 weeks is present, that it's unlikely to resolve spontaneously, but smaller angles can be observed over the first year. Then there's the European Multicenter Prospective Study, which compared early versus delayed surgical treatment in these patients. There's slight improvement it showed slight improvement in gross binocularity in the early surgery group, but there was a higher number of procedures performed in that group to achieve similar outcomes of the delayed surgery group. I really, early diagnosis is key. Correcting an amblyopia, I'll start patching right away. I really like to get these infantile esotropia patients operated on with large deviations before a year. That's what I like to do. The most common surgery is going to be bilateral medial rectus recession. If it's really large, you can use 3 to 4 muscles, but it's not typical. Most people will go just with the BMR, even for the large amounts, knowing that they might need surgery in the future. The book mentions Botox in combination or in lieu of surgery. I don't know that this is done very commonly, but it can be done. It takes a longer time to achieve the same alignment, and they need multiple injections if you do so. So the next big group is accommodative esotropia, and I find that most people are the most confused by this category. So I'm going to try my best to kind of put it in a context that's easiest to kind of understand. It's a convergent deviation associated with the activation of your accommodative reflex. So there's multiple types of accommodative esotropia, but all of them have some key characteristics. So all of them for accommodative esotropia are going to have a later onset. Average is 3. So typical story is someone coming in at 3.5 saying that they started noticing this intermittent crossing maybe 6 months, 7 months before, but it started out so rarely that they weren't sure what was really going on. But by the time they get to you, it's more constant and they're more concerned. So they'll present at like 3.5. The range is 4 months with early onset accommodative ET to 7, but it's typically later. It's going to be intermittent when it starts and progressing to a constant esotropia. It's going to be a family history. Most likely, it can be precipitated by trauma or illness. Frequently, these patients are going to get amblyopia, and if it's in a little older onset, they can get double vision, although it'll disappear once they develop a suppression scotoma. So I put this up just to kind of see where this all fits in. So you have your infantile esotropia and your required. I don't know what happened with the spacing here, but you have your non-accommodative acquired esotropia, and that's kind of all of these others. And then you have your accommodative. So don't forget that accommodative is just a form of acquired esotropia. And then under the accommodative acquired esotropias, you're going to have the refractive, non-refractive, and partially accommodative. So one way to help remember what this is and to explain it to the parents, I use this a lot, is just don't forget the accommodative triad that we learned in medical school. It's convergence, accommodation, and meiosis, and it kind of explains a lot of the kind of pathology or reason for this particular strabismus. So let's talk about refractive first. So it has all the general accommodative characteristics we talked about before, starting on later onset, intermittent at the onset, and it also has uncorrected hyperopia, accommodative convergence, and insufficient fusional divergence. Those are the three characteristics of refractive accommodative esotropia. So the angle is going to be less than an infantile esotropia. It's not going to be, over 30. It's typically going to be around 20, 25. It's going to be equal at distance and near for refractive accommodative esotropia. Equal at distance and near, and on average, they're going to have a higher amount of hyperopia. Your book and all the questions on your exams are going to be around a +4. They're really not going to show you a patient with accommodative, refractive accommodative esotropia who's like a +250. They just wouldn't do that. It's going to be someone who has like a +4, +450. So the management is full exam, treating the underlying pathology. You want to give the glasses with a full cycloplegic refraction. Any child who has strabismus, esotropia, you're going to give the full cycloplegic refraction. Patch if there's amblyopia. In all honesty, a lot of times I will start the glasses first and follow them up in about 2 months and then start patching for amblyopia. I find that a lot of times the parents are overwhelmed. Starting glasses in someone who's 3 years old is not always the easiest task. And the kids are functioning normally. They can see. They're functioning with their non-amblyopic eye, so they tend to take the glasses off. So I like to get the parents kind of baby steps, because sometimes I feel like you overwhelm them and you lose them if you start too much at one time. So it's perfectly acceptable. Start glasses, see them in 2 months. If you see amblyopia after that point, then start patching. You really want to communicate with the parents in this situation. If you don't discuss this at the first visit, even if everything is going according to plan, they will never believe you. They will always think that you did something wrong and ruin their kids' eyes. So it's really important that you warn them, I'm going to give you the glasses. The goal is that the eyes are straight with the glasses. They're still going to turn without the glasses. And in fact, it can seem worse. So sometimes without the glasses, it looks like it turns in. If they're responding to the glasses, as soon as they take the glasses off, the eyes are going to turn in. And I always warn parents about that, because, like I said, if you don't discuss it at the first visit, they're going to think you made it worse. And I usually will tell them that if their eyes seem like they're turning more without the glasses, then that's actually a sign that the treatment's working. And then you want to achieve orthophoria with the glasses. So if they're not orthophoric with their first cycloplegic refraction when they come back in, so what do? One thing is that it could be that it's no longer the full CR. So you want to cycloplegically refract them again. You could try atropine. Sometimes when they're really hyperopic and they're so used to having this tonic accommodation that they don't kind of relax their full accommodation with the cycloplegic refraction at the first visit. So after a few weeks or a few months in glasses, you can re-refract them, and you'll get underlying hyperopia that wasn't uncovered at the first exam. Or it's not purely refractive accommodative esotropia, and it's one of the other groups. One thing that parents often worry about is what happens when they reach adulthood. Are they going to wear glasses the rest of their life? And I typically will tell them, I don't know. They could grow out of the farsightedness that drives the accommodative esotropia, but we usually won't know that till the teen years. And it depends on how hyperopic they are. If they're like a +8, they're going to be a lot less likely to grow out of that. But if they're, +4, they definitely could. I usually reassure them that if they need them the rest of their life, they could always wear contacts, and they could get LASIK. There's a few studies I've read that show pretty good results 10 years out after LASIK for adults, but they don't have all of the, I don't know what happens to these patients, 15 years or 20 years after. But most of them maintain fairly good alignment, at least 10 years after LASIK surgery as an adult. I think those studies that I read were kids or adults who had the LASIK surgery in like their 20s and have been stable for a period of time. So that's refractive accommodative acquired esotropia. So now let's talk about non-refractive. So a lot of times when I talk to you guys in clinic, a lot of times there's a lot of confusion over what a high ACA ratio is. And whenever people start talking about accommodative esotropia, they start talking about high ACA ratio. But it's really important to know what this is. So it's different than acquired non-accommodative esotropia. ACA ratio is the accommodative convergence per diopter of accommodation. There's a fairly consistent increment of the amount of convergence that happens to your eyes for each diopter of hyperopia. And the abnormality in this ratio is what causes a high ACA ratio. And you can actually have excess convergence and low convergence per diopter. So non-refractive accommodative esotropia is present when the full cycloplegic refraction is prescribed and given to the patient, and the deviation is present or much larger up close. The refractive error in these patients, on average, is a little bit lower than the refractive type. It's about a plus 225, plus 250. And high ACA ratio can actually occur in low hyperopic patients, ametropic patients, and myopic patients, because it's all about the amount of convergence per diopter of accommodation. So the management for these patients, you're typically going to go with bifocals because they're turning much more up close. It reduces your accommodative convergence. You're going to want to use a flat top style or executive bifocal. Progressives are not good in these patients, and you want the top of the bifocal to bisect the pupil, and you have to write it on your prescription. Otherwise, they'll make it for adults, and it's just too low. You need it higher. The power that you're going to write for your bifocal, most people prescribed about a 250 or a 3. You can actually measure out how much they use, but I think most people just routinely will give about a 250 or a 3. So the goal of management of non-refractive accommodative esotropia is that they're going to be fusing at distance and their near deviation is going to be less than 10 diopters. Some people improve with time. They can grow out of their bifocal. Sometimes you can wean them. You start with about a half diopter or so. You start doing this around 7 or 8 and then complete around 10 or 11 or 12. And when they're older, you start to consider surgery for the near deviation to get them out of the bifocals. For this surgery, I think I touched on it in a few slides, but it's important to really discuss with the family that even after you do some type of surgical intervention to get them out of bifocals, they're still going to need their glasses for the strabismus. This is one of the things that parents don't understand the most, and you can tell them every single visit. I tell them every single visit, and I think they understand, and it's just a really hard, like, why can't you just fix their eyes? Just do surgery, just fix it. And it's really important that they're on the same page with you before you do any surgical intervention, because you really want to get this down before you do the surgery. Your book touches on pharmacologic management of non-refractive accommodative ET, but it's really not commonly done anymore. With ecothiopate iodide, it decreases your accommodative convergence by acting on the ciliary body, but it's not really used because of the side effects and would use bifocals. So surgery you're going to do for the near deviation to get them out of the bifocals. That way they can wear contacts. I've had a few people who didn't want surgery and wanted to try bifocal contact lenses. And there is a small risk of overcorrection at distance. So usually you're taught that you do the near deviation. You know, on any questions on OCAFs or boards, that's what you're going to do. But I tend to undercorrect just a bit to avoid overcorrection. And sometimes you can just observe. So it's important to remember in these patients that hyperopia does increase in kids before it decreases. So if they're esotropia, if there's strabismus, and for any of these patients, if it's changing and it's increasing, you want to make sure you redo your CR. So we've gone over refractive, non-refractive. Let's get to partially accommodative. So this is when they have a reduction in their esotropia when wearing their full prescription, but it's not completely gone. This is more likely to occur in children who have had a delay in treatment of their accommodative esotropia, so it's really important to treat early. When you have the pediatric residents rotating with you, just make sure you tell them any eye issue, send them to an ophthalmologist, because it's never okay. It's never better to wait for these type of things. You can pick things up, you can treat them, you can prevent problems. It can also be a decompensation of the refractive type of accommodative ET. So you're going to give the full glasses, the glasses for the full CR, and then you're going to do surgery for any persistent deviation with the glasses. And it's important, again, communicate with the family. They'll still need the glasses after surgery, and they'll still turn without the glasses after surgery. So now we're going to talk about non-accommodative. So there's basic acquired non-accommodative esotropia. This is an acquired form of esotropia that starts after 6 months that's not associated with any accommodative component. Usually it's a smaller deviation than congenital, and they don't have a significant amount of hyperopia. So there can be precipitating causes. The theory behind this is that these children have, at baseline, really tenuous fusion, so anything that's going to set it off will kind of put them into esotropia. So like a hyphema, preseptal cellulitis, ptosis, anything that kind of breaks up binocular fusion will then kind of spiral out of control. It can be a sign of an underlying neurologic disorder. So you're going to want to consider neuroimaging for people who have what I call kind of red flags on exam. If there's incompetence, if it's a greater deviation in a child at distance than near, abnormal head positions, double vision, headaches. Double vision in kids really isn't normal. I mean, it can happen with accommodative types of esotropia until they develop that suppression scotoma, but I really am very cautious with kids who develop double vision. So anytime you see something like that, your antenna should be up that this might be something that's, there's some type of intracranial or neurologic issue. Treatment, treat in the underlying pathology, treat the amblyopia, use glasses, surgery. Prisms can also be used for these patients, especially when they're older. That's kind of the common theme here. You want to kind of go by a stepwise fashion in their treatment. Cyclic esotropia is pretty rare. Just have one slide on it. 2 slides on it. It's usually onset during preschool years. It's comitant, and the parents will come in saying some days they look like they have a crossing, and some days they're totally fine. And so then the question is, well, do they have pseudoesotropia, or do they have actual pathology? These patients have absent fusion on their strabismic days, and they can even have diplopia on those days. And it can convert to a constant deviation. Pictures are really helpful here to differentiate between pseudostrabismus and true strabismus. Treatment is surgery for the angle of deviation during the strabismus day, and surprisingly, it doesn't really overcorrect these patients on their non-strabismic days. Sensory esotropia is an esotropia caused by monocular vision loss. The younger the patient, the more likely they're going to have an esotropia. The older the patient, the more likely they will have an exotropia. So these are patients that are going to have cataracts, corneal opacities for any reasons like Peters anomaly, temporary clouding, optic nerve hypoplasia, or retinal disorders. As kind of a repetitive theme here, treat underlying pathology, maximize their vision with glasses, patch for amblyopia, and then restore alignment kind of once you go through the previous steps. Divergence insufficiency. So this is when the esotropia deviation is greater at distance than near. It's typically comitant, and you can have primary and secondary. So primary is benign. These patients are going to be older, over the age of 50. The symptoms can improve over a few months, but it's really not uncommon. I see this a lot in the private office. But you worry that it's not primary and that it could be secondary, that it's from some type of neurologic issue like a pontine tumor, intracranial pressure that's increased, or head trauma. So a lot of times these patients will get a neurologic workup, these adults, even though a lot of times it comes back totally normal. It can even be these patients with divergence insufficiency, it could be that they have a mild abduction deficit and a sixth nerve palsy, but you're just not really picking up that deficit. So I usually err on the side of working these patients up or having them evaluated by a neuro-ophthalmologist before proceeding with any surgery. Treat the underlying pathology. These patients are more likely, the older patients, to use prisms if it's a small deviation to correct their diplopia, or if they're not surgical candidates. Some of these patients are a little bit older and they don't want surgery. They don't want to go through that, so prisms are a great option for these patients. I tend to not really use prisms in kids much because I want to restore their stereopsis and alignments to promote good vision development, but prisms are a great option for adults. Surgery, these patients are really likely to have recurrence of their esotropia, and it's really hard to overcorrect them. In actuality, when you're correcting these patients surgically, you really want to be somewhat aggressive because you're not really going to overcorrect them. I've had a few patients where, I did exactly, the right measurements, and, they had some residual, and it's just, they're really hard to overcorrect. Near reflex spasm is something that you don't really see that much of in residency, but it's something that you should really learn about, because when you're out in the private office, especially people come in, and you really should be thinking about something like this. It's something you don't see often, but it's the ciliary or convergent spasms, and there's varying degrees of convergence and accommodation and meiosis. Your book talks about how there's like a functional component versus some organic disease. These patients are going to present with an esotropia that's intermittent, times of orthophoria. It's alternating. And these patients, when you're trying to do horizontal gaze versions, they're going to start converging. They're going to start accommodating instead of kind of tracking you. And deductions are normal in spite of them having this issue with their versions. And they will have pseudomyopia because of all the accommodation. So an adult, especially who comes in with this acute onset of esotropia, who is having blurred vision, this is something to consider. And I've seen a few patients with it.
They complain of diplopia.
Yeah, they can complain of diplopia, definitely. So any adult who's complaining of something like this, I always keep this in the back of my mind. It's not that common, but I definitely consider this. But they will get diplopia, or sometimes they might not get diplopia, because if they're converging and accommodating, sometimes it really blurs their vision. So sometimes that can kind of make them not see the diplopia. Like if you're really blurry in your vision, you're not going to see the diplopia. But I've seen kind of both. And the treatment can, be fairly easy, just as, sometimes you can break them just in the office by dilating them, or you can send them home with cycloplegic agents such as atropine, cyclopentolate. Your book talks about homatropine, but I've never used that. Sometimes giving them a hyperopic correction or bifocals can help break the cycle. You want to identify any underlying triggers. Sometimes you can do Botox or strabismus surgery, but I would say you would really want to proceed cautiously with those treatments, because I would err on the side of cycloplegic refraction or cycloplegic agents or hyperopic correction. Consecutive esotropia is an esotropia in a patient who has a history of exotropia. You can have spontaneous, which is pretty rare, and those patients are going to be your kids that have cerebral palsy or some other underlying neurologic issue, or amblyopia. But the most common is post-surgical. And anytime you operate on a patient, I think you guys have probably heard all of the attendings in our department, anytime you operate on a patient for strabismus, one of the biggest risks is that you could have strabismus in the future or need future surgery. Treatment can include prisms if they're adults and having issues with double vision, giving them glasses, Botox, strabismus surgery. Your book mentions alternating patching. I'm not a huge fan of it, but it's something you should know about, I guess. If this happens post-surgery, a lot of times you're going to want to observe for a few months. Sometimes that can be your goal of the primary surgery, is to overcorrect a bit and allow it to work its way out over the first few weeks to few months. However, if it's really large or if you're concerned about a slip muscle, you're going to want to go in pretty soon. I don't think I have too much more. Esotropia can be associated with nystagmus. So fusion maldevelopment nystagmus syndrome. Basically, it's a fancy name for the fact that in infantile esotropia, you can get latent or manifest latent nystagmus. Chance's syndrome, I've never seen this, but it's infantile esotropia with an abducting nystagmus. And nystagmus blockage syndrome, these patients converge to dampen their nystagmus. So one way, it can be hard to sort out if they're having this because of nystagmus or just they have infantile esotropia. So one way you can sort this out is just to use prisms to stimulate divergence. And if you do that, you'll see the nystagmus start. But while they're converged, you're not going to see the nystagmus. So that's one way to kind of help pick that up. Some of the concomitant esotropias are discussed in other sections, so I'm just going to touch on them briefly. So there's the congenital sixth nerve palsies, the acquired sixth nerve palsies in childhood, and then adult onset. So congenital sixth nerve palsy, it can actually be an infantile esotropia that we discussed before, so don't forget about cross-fixation. Make sure you're checking ductions and versions. It can be hard to differentiate from Duane's retraction syndrome, especially because these really young kids may not get much retraction. They have shallow orbits. Also, they have poor horizontal tracking, so sometimes it can be hard to distinguish these different diagnoses. Duane's is definitely more common than congenital sixth nerve palsy. So the rule of thumb, I actually had a question of this exact type on my boards, is that a sixth nerve palsy has a very large amount of esotropia for a given amount of abduction deficit compared to Duane's. So it'll be a question like, a patient who has an abduction deficit, a child, and their esotropia measurement is like 15. So that's going to be a patient with Duane's. I mean, because that patient's going to have a really difficult time with their abduction, abduction, but they're not going to have a huge amount of esotropia. Whereas sixth nerve palsy, they're going to have a large amount of abduction issues, and they're also going to have a large esotropia. So the pathogenesis behind this is typically benign and transient. Someone I saw a patient with, or I managed a patient who was born with a sixth nerve palsy large. Was it you? Yeah. So that patient ended up getting neuroimaging, and that was normal. No intracranial pathology, no intracranial hemorrhage, and 4 months out, they were totally normal. It just went away. But I think you really want to be careful with these patients. Neurologic evaluation, getting neurology involved, consider imaging, and really close follow-up. You want to make sure that you're managing any possible amblyopia. If it's not really transient, these kids are at risk for developing amblyopia. So then there's the sixth nerve palsy of childhood, which is just the acquired, and it's more frequent than congenital. A third of these patients have associated intracranial lesions with or without other neurologic findings. It can also be due to an infectious or immunologic etiology. These patients will have, they can have double vision unless they develop amblyopia. Someone who has a history of double vision and this issue who then no longer has double vision, that's not a sign they're getting better. It's a sign that they're developing amblyopia. They'll have a head turn towards the involved side. They'll have increased esotropia in ipsilateral gaze. And they'll have slow saccadic velocities of the affected muscle and weak active force generation. You want to do a careful history. You want to find out if they've been sick recently, any fevers, viral infections, any head trauma, hydrocephalus, and obviously in adults, the whole shebang with high blood pressure, diabetes. In kids, because so many are associated with intracranial issues, you want to get neuroimaging, MRI with brain and orbits with contrast. It's really important to remember in kids that the insurance companies are going to want to do brain, not orbits, or vice versa. Sometimes you're going to be putting these kids to sleep. It's super important to fight with the insurance companies to get the study done the first time. You don't want to be putting these kids to sleep for repeated studies when they just should do it all at once. So that's something really to remember. And you're going to want these kids to get a neurologic evaluation. So if there's no anomalous head posture, you're going to want to consider amblyopia. You might want to use prisms in these children until you get the diagnosis or the underlying pathology. And sometimes if it's something that's transient, they can develop amblyopia while it's improving. Give them glasses. Botox could be an option here. And then you want to observe for a few months, and then surgery may be indicated if it doesn't improve. If there's some function of the lateral rectus, muscle, you can do horizontal muscle surgery. And if there's no function, you might want to consider a vertical muscle transposition procedure. So then there's the other concomitant esotropias, which I'm not going to go into because it's discussed elsewhere, but just know that they're thyroid eye disease, orbital wall fractures. Duane's is something that you'll see in the pediatrics department, Mobius, and sagging eye syndrome, which is basically a displacement of your posterior globe between the lateral and superior rectus and can give you some degree of strabismus. So as promised, I just, what time is it? So some more cases. So this is a 3-year-old male brought in by mom for crossed eyes. She gives you the history that either eye crosses towards the nose, but the right is more than the left. It's intermittent, started 4 months ago, and there is a family history. So your differential, it's going to be your pseudostrabismus, your infantile, and your acquired. So on examination, this patient is central steady and unmaintained in the right eye, maintained in the left eye. The anterior exam is normal. The alignment shows an intermittent esotropia of 25 prism diopters, alternating at distance and near in all gazes. The cycloplegic refraction is 450, and your patient looks like this. So, what are the maybe 2 or 3 most likely diagnoses for this patient with this kind of presentation? Accommodative. So it could be any of them, right? It could be refractive, non-refractive, or partially. What about something else? So you could have your acquired non-accommodative. Don't forget about that, which is your basic, or and then. So those are the 2 most likely things here. So I like to kind of look through your differential, and based on your exam, it's going to rule out a lot of these different diagnoses. Don't forget you're concomitant, but based on your exam that the extraocular movements are full, you're getting rid of a lot of these diagnoses. So if you have a normal exam with normal extraocular motility, no cataract, you're ruling out so many of your diagnoses that it really kind of leaves you with this, which is something that, you see a lot of that you can handle. So I think that the most likely diagnosis here is refractive. So you're going to give the full cycloplegic refraction, have them come back in 2 months. Don't forget to warn the patients that their eyes are going to cross without the glasses, and it might seem worse. And they come back in 2 months. What is your diagnosis if they're orthophoric with their glasses? Refractive accommodative. And then if there's residual esotropia, it's either mixed or non-refractive. So last case, 9-month-old girl brought in for crossing eyes, started at 6 months. It's constant and it alternates. Vision is central, steady, and maintained in both eyes. The patient appears to have bilateral abduction deficits. The alignment shows 45 prism diopter constant ET, that is comitant, and their cycloplegic refraction is +2. So give me two possible diagnoses here. Infantile, or it could be early onset accommodative. So you want to make sure you do the ductions and the versions, look for cross fixation, look for globe retraction, over and undershoots that can be associated with Duane's. You want to get a full neurologic history. Are there any other cranial nerves involved? And on further testing, this patient appears to have abduction deficits, but has full motility on ductions. So full motility on ductions, you don't have an concomitant esotropia. You go back to your concomitant, And this patient has infantile esotropia. There's no role for glasses here. They're about like a +2. Probably not going to do much given the large amount of esotropia. There's no need for patching because they're alternating and have cross fixation. It's a large deviation, so I would schedule this patient for a BMR. You want to warn the parents of the risk of inferior oblique overaction and latent nystagmus in the future. I think that's it. So any questions on any of this? I'm one of those people. I never thought I'd put pictures of my daughter up, but I was like, why not? Okay. Thanks, guys.